thank you everyone for joining. I think we are ready to start our session today. Thank you all for joining. We are excited to present this session to you, HCAHPS 2.0, what leaders, CEOs, and boards need to know about the upcoming changes to the CAHPS survey. We all know that HCAHPS is one of the most visible performance metrics and will be undergoing substantial changes. Starting next year, HCAHPS 2.0, it presents a unique opportunity not only to create momentum, but really to revitalize your patient experience initiatives. And it also provides the opportunity to re-educate and re-energize your board members, your hospital leaders, your physicians, and your care teams across the organization. So looking at this not just as a big change, but an opportunity to really reinvigorate the survey and the culture and the experience for patients. Today, our session will provide you with really valuable perspectives of the changes and hopefully will help you position you as an ambassador of the upcoming survey changes and allow you to answer those tough questions about the care experiences. So again, welcome. We had organizations from across the country that signed up to join us. So some were good morning, some were good afternoon. We had organizations from the East Coast all the way to Alaska sign up. And I know with some significant weather challenges we've had the last weeks, we understand some people won't be able to join, but we'll record this so they can hear it later. A little bit about me. My name is Kim Bixler. I'm the Vice President for Client Engagement at Healthcare Experience Foundation. I'm kicking us off today, just going to review an overview of what Katie's going to share. We listened to your, when you signed in to take this webinar, some of your priorities that you wanted to focus on this year and with the survey. And then I'm going to turn it over to Katie Owens, who's our president and co-founder of Healthcare Experience Foundation. And you can see on the agenda what she's going to speak to is really about how to engage your leaders, executives, and boards about the changes that are coming up, means to upskill the HCAHPS 2.0 changes, and lastly, how to prepare your teams to be successful with best practices. So that's what we're going to do today. We will have a chat. If we have time, we're going to be about 45 minutes for today's session. If we don't get to a Q&A, if you have questions, we'll be sure to reach out to you and answer those questions later. So who are we? For those of you not familiar, we are Healthcare Experience Foundation. I know I myself have over 18 years in the experience world, engagement and patient experience, physician engagement. Katie's got a couple decades as well. And Healthcare Experience Foundation was founded over 7 years ago. We work with organizations across the country. We do have some logos there. Thank you for your trust in joining us today. We work with organizations on best practices such as the CARES, which is our communication model, how to reinforce communication, best practices such as rounding with our relationship rounds, how to have leaders hold accountability with some of those tough conversations with our conversation curve, and our best practices in training. We work with our organizations on their experience with their patients, physician engagement, leader and staff development. And we really work to customize what we deliver to organizations based on assessments. We deliver speaking, engagement, certifications, and we can scale up, scale down in our coaching that we deliver to organizations. But we do not deliver this work on our own. Katie and I are supported by an amazing coaching team with many years in the business. I think we counted up hundreds of years, and we range from hospital leaders, physicians, nursing executives, and patient experience directors are part of our team that delivers on this best practice and world-class training and coaching that we do. And thank you all that participated when you did register. This is an opportunity for us to really hear, what your strengths are, what you're most proud of, and some of those things that we're challenged with, we have the most opportunity with. And what I like about this is, again, the opportunity to relate and not compare. We're all kind of in the same boat, struggling with a lot of the same themes. It's nice to see that the strengths were focused on health equity, teamwork, rounding some of those best practices, resilience. We saw resilience was a focus and something that organizations are proud of, which is very exciting. Seeing positive trends in patient experience, and quality care. So thank you for sharing. Those are great strengths and things to be proud of. Some of the things that you shared that you have some challenges with or some opportunities. And again, I think we all feel this. And, since I've been doing this for 18 years, it doesn't seem anything's new, but just, how do we keep focusing on these challenges is how do we get buy-in? Especially now, how do we retain our staff and how do we engage our staff is more important now than ever coming out of the pandemic. Retention, how do we hardwire some of these initiatives? Going back to staffing, staff engagement, budget, how do we scale some of these changes that are coming up? And relaunching some of the best practices. So thank you for sharing. That really helps our team know what organizations are struggling with across the country. So thank you. And just know you're not in it alone because that's a combination of everyone's input. So thank you for that. And with that, I am going to turn it over because we're going to talk about some of these strengths and challenges and how to incorporate them into wins with our new HCAHPS 2.0 survey. So Katie, I'll let you take it over.
Thanks, Kim. Hello, everyone. I'm so unbelievably excited and honored to spend this time with you together. And just for those of our dear friends and esteemed colleagues that are in Western North Carolina, Tennessee, in the Gulf Coast, and well, really 80% of Florida right now that couldn't be with us today, you each represent the call to serve that in healthcare, it's a matter of when, and just hold you all in the highest regard for how you've stepped up under some of the most extreme circumstances possible to care for your patients and community. So I'm really excited to share with you about HCAHPS 2.0, which holds a really special place in my and our team's heart. In fact, I remember this so very vividly because if anybody here has ever been pregnant, I was one of the patient experience leaders for actually one of the first offices of patient and family centered care for the country. And I was running around to the 7 hospitals in our health system, very pregnant. And now my daughter is about to turn 18 next month. And so there is nothing new to HCAHPS. HCAHPS is almost reaching adulthood. And when I look at my rising 18-year-old, still I'm reminded that being 18 is potentially far from being an adult if anybody has walked that journey. So about HCAHPS, like why did this even begin 18 years ago? Sometimes it's helpful to retrospectively look back. CMS, Centers for Medicare and Medicaid Services, made the decision that an important part of quality accountability for hospitals and health systems was to give patients a voice. If any of you who were involved in this body of work 18 years ago, so many of us were all doing our own thing largely, and some weren't doing any at all. And so HCAHPS really forced a conversation around how are we giving patients somewhat of an apples to apples comparison to hold us accountable for the quality of care as they perceive it, which we know patients, by and large, lack the healthcare knowledge. About 12% of patients have effective health literacy. Patients can't evaluate the quality. And what we know is that they can evaluate how they perceive that they are treated. And at the end of the day, while HCAHPS has always represented a rigorous standard and most of the questions being always to never, at the end of the day, when we do these HCAHPS workshops on site or virtually with health systems, any given person will always say if it's them or their loved one, they want always. And so we never want to have a different standard for what we would want to give to our loved ones and what we're willing to accept for our patients and to really close the gap. And so this was introduced. There are over 4,440 hospitals participating. It's sponsored by CMS. Began, and continues to be a bit of an apples to apples comparison. The results of HCAHPS have been consistently tied to quality metrics like morbidity, mortality, readmissions. There are over 2.3 million annual completed surveys. HCAHPS eligible patients, adult medical, surgical, OB patients we've seen in the last 18 years. more and more HCAHPS surveys come to life, as we're all working most recently to get to drive improvement with OAS CAHPS. All payer types are included, and as we still have to remind sometimes staff, and I don't say remind in a negative or a judgmental way, what I'm conveying is sometimes we think we've trained and we have to re-educate and redevelop and reinforce that the only thing we get credit for is the percent of top box responses. And in any given measure, that is the number one response of patients. Patients categorically want to be a part of a winning team. They give us always, even more often than we feel that we behave as always. And so some guiding principles with the origination was for meaningful comparisons among hospitals on issues that are important to patients. Even with HCAHPS 2.0, CMS has done extensive research and listening sessions with patients and family members around the issues that are important to their perceptions of quality care. We all know about public reporting incentives, and we're going to get into that timeline for hospitals to improve quality of care. And the goal was to enhance accountability and transparency. And so what we've also learned is that HCAHPS kind of represents a minimum standard. Are we meeting basic expectations for quality that lead to good clinical outcomes, cost-effective efficacy, consistency? It's largely a consistency scale. How often did we perform these basic tasks, and did your patients recognize this? What we have learned, and many of us even knew this 18 years ago going into this, that HCAHPS may not represent loyalty. So true loyalty is how do patients feel? What's that emotional sentiment driven by the experience of care? And then how do your patients carry that sentiment forward? Loyalty is more tied to service growth, patient-centeredness, and overall profitability and performance. And so some summary changes. We're making 5 big shifts, let alone with methodology. So the questionnaire in and of itself, it will remain in effect until December 31st of this year. We're going to go overall, it's going to be a net gain in questions. We're going to go from 23 to 22 core, but we're going from 10 to 11 measures, 6 to 7 publicly reported composites. We're making some adjustments with cleanliness will remain the same, but quiet at night is shifting to restfulness of hospital environment. CMS has added a new measure around information about symptoms, not systems. And I will tell you, we do a lot of work in our partnership with PRC around discharge phone calls and the CARES Connect program. And categorically, the number one reason for escalations for patients who are discharged home and we make a discharge phone call to are concerns around symptoms, concerns around side effects of medications. So CMS has largely kept those items intact, and in our perspective, elevated some of those behaviors that patients are now holding us accountable to. And then overall rating and would recommend are staying the same. So this is just a different look. We've also included as a resource that we'll send out the new HCAHPS questionnaire with all of the items rolled up to those composites, and hopefully an easy to cascade communicate tool for your organizations. So the hospital environment is removed because that's changing to restfulness. We're removing care transitions. We've made the wording changes to responsiveness of staff. There are no changes to nursing, physician, medication, communication, discharge information. And then we're adding restfulness of the environment, care coordination, and information about those symptoms. Methodology notables, I think CMS has heard large and clear that the landscape in research has shifted. They're adding 3 new web-first modes: webmail, web phone, webmail phone. The original or the OG methodologies will remain mail only, phone only, mixed mode, mail phone. From our perspective as coaches, where we're on the line for demonstrating improvement, telephone remains to be the most reliable methodology for having a valid response rate and to ensuring alignment with our health equity goals for representative findings across your subset of populations, especially your marginalized patient populations. We're extending the data collection period from 42 to 49 days. That's going to be a bit of a shift in how we look at our results, especially if you're using a mail survey, which takes a bit longer for those returns. No more IVR, that's going away. Proxy respondents are going to be allowed. So we're really interested in looking and studying that. And CMS has said a max of 12 supplemental items. So now's the time to be really strategic around what are the best ways to use those supplemental items, or those things that you want to rotate over given periods, so that you continue to get the rich feedback that you want from your patients. And again, this is what applies to the patients that you're doing the HCAHPS sampling and surveying with. We felt like this was important to spend a moment on because responsiveness, it's clearly one of the items that we have seen for 18 years health systems chase. And responsiveness, as we know, is always going to be in the eye of the beholder. We feel that we're responsive when we hear that call bell and we get into the room as soon as possible. Patients feel responsiveness is the moment that they had to use the call button, or they've squinted and read the 4-digit extension and dialed your iMobile or SpectraLink. They wanted help now or 5 minutes ago. So we're moving from during this hospital stay, after you press the call button, how often did you get the help as soon as you wanted it, to during this hospital stay when you ask for help right away. So that's a nuance that CMS has paid attention to. How often did you get help as soon as you needed it? And I think a huge part of the change management, which I know is a big area that many of you submitted questions on, is going to be helping staff understand these new standards and expectations. And we've got a limited runway to do that. So we're going to go, I guess, from bottom to top here. Care coordination. So this is new. Did the doctors, nurses, or hospital staff give your family or caregiver enough information about what symptoms or health problems to watch for after you left? And I think this is going to be so incredibly important for us to pay a lot of attention to, because we know patients want to pass the test during discharge. There is a high gap in psychological safety for that patient to speak up, or those family members when they don't understand, they can't afford the prescriptions, they're not sure how they're going to get the transportation to go pick up these medications, or health problems. Patients are going to evaluate this now after they are home and trying to figure this out. And so we've really got to help our discharge planning teams. If you're doing virtual nursing for your discharge planning, really get them involved in teach back methodologies. That's also something we spend a lot of time on with our clients, because we know this is a big reason why there are escalations in our discharge phone call body of work. All right, so let's look at restfulness of hospital environment. And we know the hospital will never be as restful as that patient's normal perspective, which is their home environment. So these 3 items are: how often were you able to get the rest you needed? How often was the area around your room quiet at night? We know this is not new. And then did the doctors, nurses, and staff help you to rest and recover? And so this is going to change how we manage our patient communication, how we narrate our care, because we've really been kind of monitoring noise levels. And we know for our fall precautions where the doors are open, that looks different. Patients are A, going to hear more noise. B, this is all about rest. How do we narrate vitals in the middle of the night when we are having, because it's the best care possible, the best quality of care, we have to wake patients up and monitor their vitals. We have to be able to monitor this. We have to incorporate that into our patient relationship rounds. And then care coordination. How often were the doctors, nurses, and staff informed and up to date about your care? This has been a long dissatisfier of patients. patients are really anxious, and we know 96% of patients have great fear and anxiety being in the hospital to begin with. I don't know. Let me go ask your doctor. We're going to have to eliminate a lot of words in our vocabulary, especially in peer-to-peer physician communication. And we do a lot of work with hospitalists and consultants around how to represent communication, a lot of work with staff around how to manage in the ambiguity and help patients feel that we're finding things out while we're a bit of a duck. We're cool, calm, and collected on the surface, and we're pedaling, working to get answers below. All right, next one, teamwork. This has been the universal key driver of patient loyalty. So we're super excited to see this added to the HCAHPS survey. How often do the doctors, nurses, and staff work well together to care for you? So we have to not only be an effective team, we have to display that teamwork. And then do the doctors, nurses, or staff work with you and your family or caregiver in making plans for your care after you left the hospital? And so this is going to require us to really dial up our patient and family presence and how to navigate that, because proxies are allowed now. And so many times, as we all know, there may be different players involved, whether that's a spouse, you're working with different children or other care partners. And so this is going to require us to shift. And all of this, we believe, while it's rigorous, it is reflective of what we've known patients are saying have been disappointments in their care and expectations that we have. And so we believe this helps us elevate those opportunities to serve. So some milestones. So the changes have been approved and finalized. Our best guidance is to continue to maintain your focus and use this time to prepare. Prepare your board. This, as Kim mentioned early on, this is the most public representative of what your board members can best be an ambassador for. Prepare your leaders. Leaders have to be able to talk with confidence about this as they lead their staff and physicians and clinicians forward. While we won't know yet how we perform nationally until, as you can see, really 2026, when we get comparative norms. Your vendor databases will have that information leading up to that. But this is a good time to get your PFACs involved and walk through these questions and have your PFAC share, where are you strong, where are you vulnerable. 2025, it's go time. January 1st, we will be live with the new methodology. This is going to be, Magnet just came out. And again, we can spend more time on this or in follow-up with new mappings for how HCAHPS items will roll up to the Magnet areas of evidence. Leapfrog that will continue to be that linear mean. And so while top box, and as will star ratings, let me make sure I'm precise there. Public reporting, value-based purchasing, top box, Leapfrog star ratings factor everything. And so it's our chance to figure this out and really be, I'm going to say, manage the time clock really well the rest of this year into our first levels of assessment in 2025. Come 2026, the new measures will be publicly reported for the January through December 2025 data. And then calendar year 2028, which I know feels like forever from now, but I think that's actually when my credit card expires. So it's going to come quickly. This is when our first value-based performance period will be intact for these new measures. Our team is really monitoring, especially Leapfrog right now. There's not been a lot of clear guidance there. That's just, I think everyone's trying to figure this out. And so we know we have a little bit of time, but I think we've got to use that time to help make sure our staff and our staff, physicians, and leaders feel really comfortable and confident. And that really, from our perspective, begins and ends at this stage with preparing and understanding these new accountabilities. Take the HCAHPS 2.0 survey as if you were a typical patient. Elisa Grace on our team just did that last week. We were doing sessions with leaders around HCAHPS 2.0 and connecting those that with the standards of behavior of this organization to show alignment right now and get them ready. Have them reflect on their impressions of the survey. What questions do they have? And then 1 to 3 behaviors they want to focus on to improve. Kathleen Lynham and I were just working with a client, and there was a nurse who shared in her 27 years, she's never seen the HCAHPS survey. And so we were just struck, and it's like, okay, we've got to do better. We have to really help our staff understand how patients are holding us accountable. Otherwise, it's like, back in the days before report cards were digital, it would be like our parents get sent our report card and we don't know how well we're performing in each class, how well we've done on the tests and the quizzes and the homework assignments, because we don't get the value of feedback on our performance. This is also an important exercise to do with your executive teams, and for your CEOs and board chairs to do with your board of directors or trustees. Now is the time to really, take this opportunity to further momentum. I've had the opportunity of studying national patient experience trends with Jan Ganida at PRC since 2020. And we've looked at the variability in patient performance, and we still have not regained our pre-pandemic levels of performance on the HCAHPS survey. This really represents an opportunity for collective energy and positive momentum. We also recommend a common communication platform. This is some examples of Cascade communication tools that we use. How are we clear and crisp as a leadership team what we want to accomplish with patient experience? And for our purposes here, we've isolated this to HCAHPS 2.0. At the end of the day, CMS is, and I'm not just saying CMS, AHA, AHRQ, others are, I think, guiding us as an industry in some ways. And we haven't done this ourselves. So this push is, it represents something, it represents progress to align our health equity, align our quality, align our patient experience strategies. So these are not separate and distinct. And CMS's new quality requirements, the 6 domains of leadership commitment to eliminating preventable harm, strategic planning and organizational policy, culture of safety and learning, accountability and transparency, and patient and family engagement, are continuing to tie a healthy patient experience also represents quality and equitable care. And this is a huge opportunity to help our leaders, staff, and physicians connect those dots so they don't feel like separate initiatives. It's how we deliver great care and excellent experiences. We've also included a measurement communication assessment because at the end of the day, we're introducing a new tool and we're introducing it to the same systems that we've had in place. So this is hopefully a resource for you to really look at where your strengths lie and where your opportunities are. How well do teams understand performance? Can your leaders really effectively talk with their staff about HCAHPS performance in a way that staff feel informed about areas of improvement or decrease? Do we understand and can we focus our key drivers? Do we know our irritants? Do we know these areas of dissatisfaction or disappointment? How are we using our voices or our voice of the patient themes? How often are staff getting feedback on performance? Is this something we're talking about? Especially recognitions. Are we sharing our recognitions? Are we giving a weekly or monthly briefing at our staff meetings? Do we incorporate patient rounding findings into our daily huddles? So that we're really engaging staff and physicians in solutions. And that's engaging physicians in patient experience is a real love of ours at Healthcare Experience Foundation. We had a track record of helping physicians improve 30 national percentile points on average. It just shows how much physicians are really craving tools and resources to deliver that excellent experience. We've also included some snapshots from our HCAHPS 2.0 experience guide. We have rewritten the book. We're opening up for pre-orders. And we can share, you can contact Kim or me about if you'd like to get on the pre-order list. This is a workbook for how to help your leaders really get your staff and physicians engaged in action planning and dial up their awareness of the tool. Because, action plans require specificity, and how we help our staff really connect their day-to-day behaviors helps staff feel like they're not just chasing a number, which we never feel good about if we think about any of our time in those roles. We've also included just some tools to think about maximizing your runway. What are resources to support your board getting up to speed, and getting their excitement and endorsement and confidence that management has their arms around this and is going to represent the organization well, especially by the time 2026 rolls around and our new results are public. Tools for your senior team so that they are aware and able to lead with the nuance that the new survey represents and reinforce among their direct reporting relationships, ways to keep that momentum moving. Involving your department leaders, your MEC, are all important ways of creating that cascade communication and momentum. Physicians and APPs, I think, if I rewind the tape back to circa 2006, when we were all working to get this off the ground to begin with HCAHPS, the original HCAHPS, I don't think we did a good enough job getting our physicians and providers involved early on. And I remember doing some small group sessions with physicians. And at the same time, when I wish I could take, 2024 thinking and apply it back to 2006, because I think we've missed opportunities, and it really helps us strengthen that collaboration, which we know peer-to-peer communication, physician to staff communication will be evaluated, and we have to address that interprofessional communication. And I would also put a plug, and I would do this no matter what our webinar topic is, pay attention to your charting. We have got to be really mindful that we are neutral and affirming in our charting. We have got to look at bias charting and mitigating using language that marginalizes our patients, because this open access charting is now available. And I can't tell you how many chart wars I have seen, or our coaching team has seen working with our clients, where staff will talk about, or physicians will talk about, disagreements in treatment plans, readiness to go home. And so many issues are involved in that from a risk standpoint, jeopardizing quality. It's also going to be on the HCAHPS survey. Are we informed about your care? And if patients are reading in their chart that there's disagreement, we've got a problem. Staff, and then, and really being clear and onboarding your new leader, staff, and physicians. And I think that's often an overlooked opportunity that we're eager to see more holistically addressed. And I know we're talking a lot about board engagement here. We have our trustee article that I had the privilege of co-authoring with my dear friend Laura Orr at Forward Governance around the board's role in advancing the healthcare experience. We also have our board engagement strategy, best practice resource. So some tips that we've seen and that we're really advocating for with our clients: align awareness holistically. We have HCAHPS 2.0 coming. We have the new CMS safety requirements. We have our health equity alignment. Share our patient experience strategic plan with a specific lens on ways to enlist the board. Invite board members to be a part of recognition. We do a lot of work with whether that's facilitation with boards, board presentations, board engagement work. Boards want to be a part of seeing and experiencing how care gets delivered, not because we want to cross the lines between governance and management, but Just like we look for that sense of purpose, our board members are looking for that sense of purpose. Consider an annual board recognition event. This was something we took a lot of pride in a prior health system that I was a part of. We had an annual big event, and it was used to celebrate patient experience leaders, units, staff, physicians, and really it was showcasing these wins in front of our board, which was such a big deal. I almost used the word contagious. Well, I just did. And that's sort of become a word we don't want to use these days. Open board meetings with mission moments and recognition of patient experience. Provide trustees with information around your system awards and designations. I would also say make sure your board is aware and ahead of any disappointments. Maybe you thought you were going to come out, one way with Leapfrog, it went a different way. Have your boards want to be ambassadors, and they want to represent you well in the community. And to do so, they need communication points and education on, these recognitions, how this is calculated. They don't need the nooks and crannies, but they need enough to be able to be an ambassador on your behalf, answer tough questions, speak to why, especially if you've had a disappointing star rating or Leapfrog result, how to speak positively of your patient experience strategic plan. So they need communication cascade tools. And then also, just like we advocate leveraging your PFACs for their perspective and expertise, your boards have tremendous expertise and knowledge, not only of the communities that they represent, the industries they represent, but they also want to be involved and they want to be asked the question. And so curing their ears and eyes are also a great way to continue to foster that collaborative spirit between management and governance. We also wanted to just talk about, when we think about this runway and we think about what are we seeing have the greatest impact on HCAHPS, we're seeing within our team the effects of our CARES highly reliable communication model. We're seeing significant gains in HCAHPS and loyalty and quality and safety, and it's creating a more support for health equity and inclusive care strategies. Our relationship rounding, curriculum and application to re-engage conversations with senior leaders, employees, and physicians, and patient and family rounds, and then our CARES Connect program with PRC, validating that safe transition home. We're going to be doing an upcoming webinar on the findings of some new research from that program on, spoiler alert, improving value-based purchasing 46%, and now demonstrated connections to lower readmissions for our patients who are receiving a CARES Connect call. So we're getting the benefit of HCAHPS. It's fitting into many organizations' health equity action plans. And we're now seeing reductions in readmission and a chance for that last service recovery before a patient receives an HCAHPS survey. So I want to make sure that Kim and I open up to any questions that you have in chat, so that we can address those, or if we need to do further research, or if there's any additional resources you need from our team. We have our Healthcare Experience Matters podcast that I highly encourage anybody who wants a daily, not a daily, that would be a big time request, a weekly dose of information or inspiration. These are some recent topics. I think we just had Dr. Jim Longquist talk about how physician engagement and patient experience also leads to quality outcomes. I think, Kim, that came out today. And any support beyond today for HCAHPS 2.0, I mentioned we are releasing our pre-orders. We've been taking some informal ones for HCAHPS 2.0. We can also do workshops on site or virtually, as well as custom improvement roadmaps. We also have our Healthcare Experience Academy video library of micro-learnings that we're in the process of redoing all of those videos for the new HCAHPS 2.0, which we are really excited about. Relationship rounding, application and assessment certificate programs. Actually, tomorrow we have our relationship rounding certificate program. our last one for the year. We're so excited about that. And so we have our Healthcare Experience Matters, our certificates, and then we also post a lot of resources to LinkedIn for those of you already following us or are new to us.
Thank you so much, Katie. I hope everyone on the call found this instructional, really valuable use of your time. We do have a few minutes left. If there's any questions you want to put in the chat, or we want to let people raise their hands. But again, thank you so much. If you do have any questions, follow-up, need for resources, we are here for you. And thank you so much for your time today. We so appreciate your partnership.